So what's up with the atypical antipsychotics? Well, the atypicals actually cause psychiatrists to completely rethink the dopamine hypothesis, because while all of them block the D2 receptors, and many of these only block the D2 receptors weakly, some of them are actually thought to be primarily effective through serotonin receptor blockade at the 5-HT2 receptor, and some of their efficacy is thought to involve the blockade on the alpha-adrenergic and the histamine receptors. The fact is, while dopamine probably plays a role in managing the positive symptoms of schizophrenia, we don't actually know what treats the negative symptoms. The step one party line has always been that atypical antipsychotics treat the negative symptoms better. But we don't quite know what combination of receptor activity is really responsible for treating those negative symptoms. So let's introduce our lineup. The drugs you'll have to remember for this test are olanzapine, clozapine, quetiapine, risperidone, aripiprazole, and ziprasidone, which can be remembered by the vaguely psychotic mnemonic, "It's atypical for old closets to quietly whisper from A to Z." Side note, guys, if any of your closets are whispering the alphabet to you at night, you, 1, may need an atypical antipsychotic, and 2, need to go back to grade school because it's whisper, not risper. Now, I do a lot of generalizing with the drug classes, but it's important to remember before I start that any generalizations that I make about the atypical antipsychotics should not be assumed about clozapine. Clozapine's clinical use is actually a lot different from other atypicals, and it practically needs to be thought of as its own drug class. We'll talk about that in a sec. The other ones, though, are first lines for most of the disorders that you use the typical antipsychotics for. Remember what those were again? Psychotic disorders and acute mania. That's mostly what the atypicals are used for. But more recently, they actually also found use in the treatment of mood disorders and actually some anxiety spectrum disorders. Now, those uses don't matter so much for step one, but who can tell me? Why do we love the atypicals so much? Why are we using them for just about everything under the sun? Well, in general, the high-potency antipsychotics are known for their potentially dangerous anti-dopaminergic side effects. The low-potency antipsychotics are known for their irritating and sometimes treatment-limiting anti-HAM side effects, particularly the anticholinergic ones like urinary retention. The atypicals, on the other hand, have the wonderful ability to combine low D2 activity with an extremely low incidence of anti-muscarinic side effects, so you're not going to get the urinary retention. The amount of sedation and orthostatic hypotension actually varies a lot based on the specific drug, but the worst side effects, the dopaminergic and the anti-muscarinic ones, are generally kept pretty low. So what's the catch with atypical antipsychotics? Atypicals have no clear benefit when it comes to QT prolongation, but this varies a lot with a specific antipsychotic. Probably the most important thing to know is that while all antipsychotics can cause metabolic syndrome, many atypicals cause more than their fair share. Olanzapine and clozapine are particularly notorious for this. Finally, while most antidopaminergic side effects are minimized with atypicals, risperidone, interestingly enough, causes the most prolactin elevation. Just to review, what's this most likely to lead to? So it can lead to galactorrhea, but it's most likely to lead to sexual dysfunction and/or amenorrhea due to GnRH suppression. We're going to wrap up with clozapine, which is kind of like the black sheep of the atypical antipsychotic family. We already know that along with olanzapine, it's got the highest risk of metabolic complications, like weight gain and diabetes. It also comes with a seizure risk, but the complication that you have to worry the most about is agranulocytosis, where the bone marrow granulocyte production is suppressed. Do you remember the granulocyte lineage? Well, the granulocyte family consists of neutrophils, basophils, eosinophils, mast cells, actually that kind of most of the white blood cells. So agranulocytosis can obviously lead to a fatal immunodeficiency, and because of this side effect, you have to monitor a patient's white count on a weekly basis if you're going to be prescribing them this drug. It sounds like clozapine's got some pretty lethal side effects, and makes patients who are already non-compliant come in for weekly monitoring. So that begs the question, why would anybody use it? The short answer is, it's the best. It is the most effective antipsychotic of all the typical and atypicals, and it even works on schizophrenia that was previously resistant to medical management. Finally, it has the weakest dopaminergic activity of all the typical and atypical antipsychotics, meaning that it has almost no risk of EPSs, meaning extrapyramidal symptoms, neuroleptic malignant syndrome, or elevated prolactin. The bottom line is, clozapine is the big gun of schizophrenia. But unlike other atypicals, it's not a first-line kind of drug. You only use it if the other treatments have failed. And that covers the antipsychotics. There's a lot of different drugs and a lot of different side effects to know, but hopefully this presented them in a concise, effective manner. Let's take this one step further and apply your knowledge to a vignette. Get ready to test yourselves. You have a minute and a half to answer this question. A 22-year-old man with schizophrenia is being treated as an inpatient with a first-generation antipsychotic medication. Several hours after his initial dose, he develops involuntary muscle spasms, particularly in his facial muscles. To which class of drugs does the indicated treatment for this patient's adverse effects belong? Is it A, beta blockers, B, anticholinergic agents, C, anti-epileptic drugs, D, atypical antipsychotic agents, E, dopamine agonists, or F, mood stabilizers? So, this really is a multi-step question. One of the best things you can do in this case is to skip straight to the bottom to figure out what exactly it is you're supposed to be answering. In this case, the question's asking you which class of drugs you need to use to treat the patient's side effects that he's experiencing right now. Keep in mind, this is worded pretty strangely here, which is unfortunately not unheard of when on the actual step one. So when you read the question, it becomes clear that this guy got a first-generation antipsychotic and pretty soon afterwards developed muscle spasms. Remember, because with the antipsychotics, time course can be important, it's important to realize that it's several hours after his first dose when he's still in the hospital. Sound like any side effects you know? It's acute dystonia, a side effect that's known for happening pretty soon after you administer the medication. Remember, acute dystonia occurs as a result of decreased nigrostriatal dopamine, and in that pathway, ACH and dopamine essentially counteract each other. So if the problem is decreased dopamine, you correct the movement disorder by also decreasing the acetylcholine in the basal ganglia. So let's go over some of the incorrect answer choices and trap answers. If the patient is schizophrenia, you really want to avoid giving him a dopamine agonist. Now, some of you might have thought this is a logical choice because the problem was with dopamine blockade, so you might want to increase the dopamine. You don't actually do this for the extrapyramidal symptoms, because remember, they're on antidopaminergics for a reason. They're going to go into full-blown psychosis if you give them a dopamine agonist. You are, however, permitted to use dopamine agonists in the life-threatening syndrome, neuroleptic malignant syndrome. But for the extrapyramidal symptoms, you definitely don't want to use these. Now, you may have confused the patient's symptoms for a partial seizure and opted to give him anti-epileptics. That's kind of understandable because they can look pretty similar. However, while there are a ton of side effects associated with the antipsychotics, seizures aren't really a major risk for any of them besides clozapine, which is a second-generation antipsychotic. So anti-epileptic drug is not the right answer. And while maybe you should have tried a second-generation or an atypical antipsychotic initially to avoid the dystonia, saying shoulda, coulda, woulda and giving him an atypical now isn't going to treat the dystonia that he already has. A couple of the others, beta blockers, they're used for tremors, not muscle spasms. And honestly, I have no idea why mood stabilizers are on this list. That doesn't make any sense to me.